Assalamu alaikum, everyone. My name is Manar and I graduated from Imam Abdurrahman bin Faisal University. I had my internship in King Fahad Specialist Hospital, and I hold a Bachelor of Respiratory Care. So in this lecture, I'm going to be talking about ECMO, which is extracorporeal membrane oxygenation. But before I start, I have to say that this is not an in-depth presentation. I'm just going to highlight the topic. So I'm first going to talk about an introduction and the history of ECMO, and then I will go into the components, the types, the contraindications, the ventilator settings, and monitoring, weaning, and lastly, complications. So what is ECMO exactly? ECMO stands for extracorporeal membrane oxygenation, which is the use of a temporary heart-lung machine, which is shown in the picture, to support patients with an increased risk of death. And it's very important to highlight that we're using ECMO for patients with an increased risk of death. So basically, it's a last resort. However, we should take the decision of using ECMO early on, not very late, because the earlier we use the machine, the better the outcomes. So we can use it on patients with reversible conditions such as respiratory failure or cardiac failure, and we can also use it in case we want a bridge to transplant or a device implant, so heart transplant or lung transplant. We have two types of ECMO. We have the Venovenous ECMO and we have the Venoarterial ECMO, and I'm going to dive into them later. But first, I have to talk about the history of ECMO and how we got to the point we're in right now. So it started with the bubble oxygenator in 1882, and then in 1916, they discovered heparin, which was very essential because up to this point, they were having so much trouble with blood clotting and worsening the condition of the patients. And then they discovered heparin, and this thankfully solved this problem. And until now, we're using heparin to use ECMO properly. And in 1929, they successfully did an extracorporeal perfusion of a dog in Russia. In the 1930s and through the 50s, there were further developments of the oxygenator, such as the all-glass oxygenator. And in 1953, the first successful cardiopulmonary bypass machine was done. And in 1958, the development of the first membrane oxygenator, which we still use to this day. And then thankfully, in 1971, the first person ever survived ECMO. This was a 24-year-old patient who survived a car accident. He survived, I believe, 72 hours on ECMO. And then this is a very big milestone in the history of ECMO. So they did the first successful neonatal ECMO by Dr. Bartlett on an abandoned baby who had meconium aspiration syndrome. This baby had meconium aspiration syndrome, and the staff named which translates to hope. معلش بس في أحد فاتح المايك. So this neonatal baby, she suffered from meconium aspiration syndrome, and the staff named her Hope, and she survived ECMO, thankfully. Now this is Esperanza many years later with Dr. Robert Bartlett, which went on to be a big name in the ECMO industry, and he was actually nicknamed the father of ECMO. In 1978, they described the CO2 removal, and in 1979, they did a randomized control trial of adult patients who had ARDS, but suddenly the survival rate was very low, standing at 10%. So this just closed the doors on adult ECMO. However, pediatric ECMO and neonatal ECMO went on to be successful. And in 1989, the ELSO Foundation was founded, which stands for Extracorporeal Life Support Organization. Now, this organization is responsible for data collection of best practices for ECMO use. In 2009, the H1N1 flu pandemic happened, and they collected many data on ECMO success for those patients. And in 2009, the CESAR trial happened. Now, this is a very big milestone in the development of ECMO because in the CESAR trial, they assigned 180 patients to either conventional mechanical ventilation or ECMO. And the patients suffered from severe acute respiratory failure. And they found that the patients on ECMO had higher survival rates than conventional mechanical ventilation. And after this trial, many studies were done in the same conditions, but this is the one that started everything, and it was a very big milestone in the history of ECMO. Now I'm going to talk about the components that are present in the device. Now this is a diagram explaining the machinery inside the device. We've got the cannulas, the pump, the oxygenator, the O2 blender and flow meter apparatus, the heat exchanger, and the monitors. So the cannulas, as we can see, we have two types of cannulas, the venous cannulas, which are much longer than the arterial cannulas. Both cannulas are very big and bulky, and they're lined with metal rings that prevent them from collapsing in on themselves. And then we have the pump. So the blood goes into the venous cannulas and then goes through the pump. Now we have two types of pumps, the roller pump and the centrifugal pump, which is more common. Now the pump drives the blood around the circuit, and then the blood goes into the membrane oxygenator. Now this is the main device that actually oxygenates the blood. It has small fibers inside that contain oxygen from the O2 blender and the flow meter. So the blood goes around those fibers and gets oxygenated and then goes again into the arterial cannulas, and then they go into the patient's body. We also have the heat exchanger, which warm the blood before it actually goes into the body. It heats the blood using some saline solution that's warmed up. And then we have the monitors. Now the monitors are very important. We have the pre-membrane monitor and the post-membrane monitor. Now they're both pressure monitors. They help us calculate something called the delta P, which is the driving force of the blood inside. Now this delta P helps us identify if there's any clotting happening inside the membrane oxygenator, because if there are clots in the membrane oxygenator, this means that the resistance will be higher. So if the delta P is higher, it tells us that there are in fact clots inside the membrane oxygenator, and we have to solve this problem, because if we let this go on, the clot will go into the patient's body and causing many problems such as pulmonary edema or even strokes. Now I'm going to go into the ECMO types. We have two types, the venovenous ECMO and the venoarterial ECMO. I'm first going to talk about the venovenous ECMO. So it's called venovenous because we're taking blood from a vein and putting it back into a vein again. The main purpose of VV ECMO is gas exchange. So basically, it gives respiratory support. It basically takes place of the lung or supports the lung until the lung can regain its function back. So we can use it in hypoxemic respiratory failure. It's considered when the PF ratio, which is the oxygenation ratio, is less than 150, and it's highly indicated if the PF ratio is less than 100. We can also use it in hypercapnic respiratory failure when the pH is less than 7.2, and we've already used our ventilation strategies, but nothing seems to work. We can also use it to bridge to lung transplant. Now this just explains itself. So we want to remove the native lung and transplant a new lung, but we also want to oxygenate the body. And how do we do that? By using ECMO. So the blood goes out into the machine and then goes back, skipping the lung completely. And that allows us to transplant the lung and then eventually give the lung time and give the body time to identify the new lung or the new organ. And then we can just disconnect the ECMO when the patient's ready. So as for the conditions, we have the ARDS, which stands for acute respiratory distress syndrome, airway obstruction, pulmonary contusion, smoke inhalation, and air leak syndromes. All these conditions can benefit from ECMO use. And as for the criteria, we can use it when the PF ratio, which is again the oxygenation ratio, is less than 100, and the patient is on PEEP of more than 10. The FiO2 is more than 80%, and there is no improvement in the past few hours. And the P-plat is more than 35, which is very dangerous. And the oxygenation index is more than 40. Now this is a picture of how we insert the ECMO, or where it's inserted. So we drain the blood from the femoral vein right here, and then it goes into the machine and then out of the machine into the internal jugular vein. Now we can see the white line, which represents the cannula. It goes in until the inferior vena cava, and then the top cannula, which is the return cannula, it goes into the superior vena cava. So this is another picture just showing us how the flow of the blood. It goes from the femoral vein and then into the centrifugal pump, oxygenator, and then it's oxygenated, and then it goes into the internal jugular vein, into the superior vena cava, and then it goes inside the right atrium. Now that's in the case of single lumen cannulas. We have something else called the double lumen cannulas. It's basically two lumens inside of one big lumen, inside of one big tube, and then it just goes into one place, which is the femoral vein right here, but there is no cannula at the bottom here. Sorry, it goes into the internal jugular vein, but not into the femoral vein. So it's one cannula with two lumens inside, and then it stops when it touches the inferior vena cava. And using fluoroscopy and endoscopy helps us locate where it stopped. So it draws blood from the inferior vena cava and the superior vena cava into the deoxygenated blood cannula, and then the blood goes into the machine, the ECMO machine, goes back again through the oxygenated blood cannula, and then this port right here pushes blood out into the right atrium. Now, why do we want to use the double lumen cannula? It reduces something called recirculation, which is basically mixing of deoxygenated blood with oxygenated blood. And that just, we don't want that to happen, of course, because when the oxygenated blood is mixing with the deoxygenated blood, it's actually taking place of the blood that needs to be oxygenated. So this just reduces the amount of oxygenated blood going through the body. So that's why double lumen cannulas are very beneficial. As for the venoarterial ECMO, it's venoarterial, so it takes blood from a vein and returns it back to an artery. The main purpose of the VA ECMO is to oxygenate and pump blood to the body, meaning it gives support to the cardiopulmonary system, not only the pulmonary system. So we can use the venoarterial ECMO in case of refractory cardiogenic shock when the patient is on more than 2 inotropes and or has a heart device. We can also use it post-operative heart failure, and peri-procedural for high-risk cardiac interventions. That just means that we can use it before, during, or after any cardiac interventions. We can also use it as a bridge to transplant or device implant. And as for the criteria, when the patient has low ejection fraction, like less than 20%, thickened ventricle walls, and on max inotropes, has a low heart rate, and he has a history of arrest, he can benefit from venoarterial ECMO. Those two pictures show us where the cannulas go. So the blood drains from the femoral vein, goes into the machine, and then drains into the femoral artery, or the right carotid artery, or the right subclavian artery. So as we can see, we take blood from a vein and then we return it back to the artery opposite to that vein. And this is just another picture to demonstrate that we can place the return cannula in this one or this one. Now I'd like to talk about the contraindications of ECMO. How do we know that this patient will not benefit from ECMO and the complications will actually be much worse than the benefits? So we have absolute contraindications and relative contraindications. As for the absolute contraindications, prolonged CPR without adequate tissue perfusion, because it just means that the patient has poor prognosis. There is not a transplant candidate, so we have to know and we have to make sure that there is in fact a transplant candidate to use ECMO to bridge to the transplant. Otherwise, we will not benefit from the use of ECMO. Unrepaired aortic dissection. Aortic dissection is and severe aortic regurgitation. So these conditions will put more load on the heart when we return the blood back to the heart. So it will just worsen our case instead of benefiting the patient. And unrecoverable severe brain injury, severe organ dysfunction such as emphysema, cirrhosis, renal failure, and also pulmonary hypertension. As for the relative contraindications, we've got obesity. Just because obese patients have many underlying conditions and have a higher risk of clotting and respiratory compromised lung function. And also, it's very difficult to cannulate obese patients. So it's relatively contraindicated to use ECMO on obese patients. Also advanced aged, so like above 70. The same case with obesity. Like they have many underlying conditions that will just worsen the case instead of benefiting them when using ECMO. Pre-existing chronic illness with long-term poor prognosis, prolonged mechanical ventilation more than 14 days. Because prolonged mechanical ventilation poses the patient for a risk for lung injury and lung infection. So the same case with ECMO, they will just worsen the case. They will not benefit from the treatment. Now, as for the ventilator settings while the patient is on ECMO, it's advisable that we keep the patient initially on pressure control and on a very low rate of 5 to 10 breaths per minute. It is also advised to keep the PEEP of 10 initially, and then we can titrate the PEEP depending on the patient's condition. And then we want to keep the tidal volume low, so 4 to 6, advisably 4. Some sources also say to reduce the tidal volume to 50% of the previous value. So for example, if the patient was on 500 tidal volume, we're going to reduce it to 250. And then the FiO2, we'd want to keep the FiO2 as low as possible. So if we can keep it to 21, that's perfect. If we can't, we're going to try and keep it less than 40%. And then, of course, we have to monitor the plateau pressure at less than 30. And it's even better if the plateau pressure is less than 25 because even 1 centimeter of water can make a difference in the ICU stay and the weaning of the ECMO device. And I'd like to also talk about prone positioning. Now, I haven't put it on the slides, but it's very important to consider prone positioning when we can because it does improve oxygenation, especially that we're using a whole external machine to improve oxygenation. So just why not incorporate another oxygenation improvement modality? So next, I will talk about the monitoring. We're going to have to monitor the venous saturation. Now, this gives us insights about something I've talked about before, which is the recirculation. If the venous O2 is high, this means we have a high rate of recirculation, but we have to keep it in the normal range. We also have to monitor the temperature of the patient, the pressure in the circuit. As I've said before, the delta P helps us identify if we have any clots inside the membrane oxygenator or not. We also have to monitor the systemic blood pressure, the hemoglobin, the blood flow, basically the hemodynamics of the patient. And lastly, we have to monitor the platelet count and the activated clotting time. This gives us insights about the bleeding or clotting that's happening inside the machine or in the patient's body. And now I would like to talk about weaning off the ECMO machine. So first we have to assess the improvement of the patient. Is he eligible to be weaned off the ECMO machine, or does he need a bit more time? As for VV ECMO, which is Venovenous ECMO, we have to know that the respiratory function is improved. And how do we know that? We see that the arterial saturation becomes greater than the central venous saturation. This just means that the oxygenation cycle is back to normal and is good again, and the patient can be, in fact, weaned off the machine. We also have to know that the patient is hemodynamically stable. And of course, the underlying cause is treated. And then, as for the VA ECMO, since it's a cardiopulmonary support machine, we're going to have to make sure that the cardiac function is improved, so contractility and arterial pulse is improved. And we also have to make sure that the patient is hemodynamically stable. Now, going into the actual weaning of the machine, I'm starting first with the VV ECMO, the venovenous. First, we're going to gradually reduce the ECMO blood flow to allow the lung to function independently. And then we're going to increase the ventilator settings gradually. And then we're going to reduce the sweep gas flow gradually as the patient's lungs improve. And then we're going to do a very important step right here. It's to clamp the tubing to the patient and then increase inotropes. But we're going to clamp the tubing to make sure that the patient can, in fact, function by their own. The lung is fine, the heart is fine, they're back to semi-normal, they can function without the machine. If the patient is stable for 4 to 6 hours, they can be decannulated. But clamping the tube just gives us more safety that if the patient is not stable, we can just unclamp them, and then they will go back, the blood will go back to the machine, and we will redo the cycle again, instead of decannulating the patient and then cannulating the patient again. As for VA ECMO, first we're going to gradually reduce the ECMO blood flow to allow the lung and heart to function independently. And then we're going to increase the cardiac output. And how do we do that? It's by optimizing the preload, afterload, and inotropic support as needed. And then we're going to reduce inotropic support as the patient's cardiac function improves. Now, by reducing the inotropic support, we're giving the heart a chance to improve and do better on its own without any external support. And then we're going to clap the tubing to the patient and increase inotropes again. And then if the patient is stable for 4 to 6 hours, perfusion and gas exchange are fine, we can decannulate the patient. Now, throughout this whole process, of course, we have to make sure that the patient is hemodynamically stable, the blood gas is good, and the overall condition is stable. I would also like to talk about mobilizing and ambulating on ECMO. So this just means that we're moving the patient while he's on ECMO. Now, I put those two studies. The first study is actually talking about the fact that ambulating, is it safe or is it not? And they found that it is in fact safe, and it can be done on ECMO patients. And then I put this other study that's talking about if it's actually beneficial to ambulate the patient. Okay, it's safe, but is it beneficial? Does it improve the survival rate? And it turned out that yes, it does improve the 30 days survival rate, and it decreased the ICU stay. So ambulating on ECMO should be interpreted more in the hospitals with the help of an experienced staff. So these are pictures of patients on ECMO that are ambulating. This patient is going outside, and this patient is walking on a treadmill. Now we can see that there are a lot of staff going with the patient, because we have to make sure that the tubing position is right, the patient's condition is okay, he's hemodynamically stable, he can in fact walk, and yes, I think we should reinforce ambulating and mobilizing on ECMO, even if we're just moving the legs and arms, and the patient is cooperating with us. Just any mobilization, I think, will do a difference. Now I'd like to talk about the complications of ECMO. So standing at the top, we have bleeding on 40%. Now bleeding, we control it by preventing it more than treating it. So we have to know that the heparin dose we're giving the patient is actually okay and not causing any internal bleeding. And the next complication is clotting, which is present in 15 to 20% of the cases. Now, as I said before, we have to monitor the delta P, which is the driving pressure inside the membrane oxygenator, to know if there are any blood clots. Because if we let the blood clots flow into the arterial cannulas and into the patient, um, it's just we will have pulmonary edemas, strokes, you know. And then lastly, we have infections, and this is just a risk um, uh, in any invasive procedure. But hopefully, if we follow the antiseptic and sterile precautions, we will be fine. So I've reached the end of my presentation. Thank you all for listening, and I appreciate your time and attention. And I hope this presentation provided you with any valuable insights. If you have any questions, feel free to contact me on my email, or just write it in the chat.
ما شاء الله تبارك الله، الله يعطيك ألف ألف عافية، ما شاء الله. شرح رائع جدا، الله يسعدك يا أستاذة منار، ما شاء الله تبارك الله. يا جماعة اللي عنده أي سؤال لأستاذة منار يتفضل. يا جماعة اللي عنده أي سؤال يتفضل، إذا بتفتحون المايك أو تكتبون في الشات.